You know, we hear a lot about snoring and sleep apnea, these problems that happen when we're asleep. But what if there was a breathing disorder that was affecting you all day long, even when you're wide awake? Today, we're diving into exactly that. Obesity-Hypoventilation Syndrome, or OHS. It's a really serious condition that, honestly, is often missed.
And to really get a handle on this, I think the best way is to start with a story, a real-world case that had doctors scratching their heads and shows just how critical it is to catch OHS.
So let's picture this. A 62-year-old man shows up in the emergency room. He is in serious trouble, having a really hard time breathing. We're not talking just a little winded. He is gasping for air. And for the medical team there, the clock is officially ticking.
So, they immediately get his vitals, and the numbers are just screaming that something is wrong. His heart is racing, way over 100 beats per minute. His oxygen level has dropped to 90%. He's breathing way too fast. On top of that, they see his feet are incredibly swollen, which is a classic sign his body's holding on to fluid. And when they listen to his heart, they hear this extra sound, this kind of gallop. These are all huge red flags.
Now, with all of that going on, the first thing everyone thinks is heart failure. And that makes sense, right? It fits the clinical picture perfectly. But as they start to investigate, they get this feeling that maybe they're missing something. Could heart failure just be a piece of a much bigger, more complicated puzzle?
And this is what brings us right to the heart of our patient's mystery. It's a condition that can look a lot like its more famous cousin, sleep apnea, but it comes with this really dangerous daytime twist.
So this is it, Obesity-Hypoventilation Syndrome. Now that term hypoventilation sounds complicated, but it just means your body isn't breathing effectively. You're not getting rid of enough carbon dioxide. And the really critical part here is that this is happening while you are awake, not just when you're sleeping. And it's tied directly to having a BMI over 30.
Okay, so this is maybe the most important slide. How is OHS different from obstructive sleep apnea, or OSA? Well, think of OSA as a plumbing problem. It's a physical blockage in your throat that happens when you're asleep. But OHS is a problem with the command center. The brain's fundamental drive to breathe is just weaker. And because of that, your CO2 levels are high all the time, day and night. That's a huge difference from OSA, where CO2 levels are usually normal when you're awake.
So why? Why does this happen? I mean, what is going on in the body that weakens something as basic as the drive to breathe? Well, the science tells us it's this kind of perfect storm of three interconnected issues. First, there's just the sheer mechanics of it. Excess weight on the chest and belly physically makes it harder for the lungs to do their job. Second, the part of your brain that controls breathing just becomes less sensitive. It stops reacting properly to high CO2 levels. And third, and this part is fascinating, the body starts to resist a hormone called leptin, which it turns out is super important for breathing.
Now this is so cool. We usually think of leptin as the hormone that tells our brain, hey, you're full, you can stop eating. But what most people don't know is that it also sends a signal to the brain that says, hey, breathe more. In people with OHS, there's tons of leptin being produced by fat tissue, but the brain has become resistant. It's just ignoring the signal. The breathe more text message is never even read.
This is the perfect way to think about it. Imagine that high carbon dioxide is like smoke filling up a room. In a healthy person, the smoke alarm, which is your brain, goes off immediately, and you start breathing faster to clear out the smoke. But in OHS, that smoke alarm is broken. The CO2 smoke is just building up, and the alarm just never goes off. The brain is asleep at the switch.
Okay, so let's get back to our patient in the hospital. The doctors are armed with this knowledge about OHS. How do they actually go from just a suspicion to a rock-solid, definitive diagnosis?
Well, they start looking for a very specific pattern of clues. First is the patient's BMI over 30. That's a must. Next, they run a simple blood test and look at bicarbonate levels. If they're high, over 27, that's a huge red flag because the body creates extra bicarbonate to balance out the acid from all that retained CO2. And finally, they see that the patient's oxygen is low even while they're sitting there wide awake.
But all those things are just clues. They point you in the right direction. To get the smoking gun, the one test that proves it, you need an arterial blood gas analysis, or an ABG. This is the gold standard. It's not a guess. It's a direct measurement of the oxygen and CO2 in the blood. And right here, this is the magic number. This is what it all comes down to. If that ABG test shows that the level of carbon dioxide in the arterial blood, the PaCO2, is greater than 45, that's it. That's the diagnosis. It's the objective proof that the body is failing to ventilate properly.
And for our 62-year-old man, this was the aha moment. His ABG came back and his CO2 was way above 45. Suddenly, everything clicked into place. It wasn't just heart failure acting on its own. The real driver, the underlying condition causing this whole crisis, was severe and undiagnosed OHS. So, now that the case is cracked, what's next? I mean, this sounds really scary, right? But the good news is there's an incredibly effective treatment that can completely turn things around for these patients.
The absolute cornerstone of OHS treatment is something called positive airway pressure, or PAP therapy. You've probably heard of a CPAP machine for sleep apnea. Well, we're talking about that same kind of technology.
PAP therapy is an absolute game changer. That constant stream of air does two things. One, it acts like a splint to hold the airway open at night, which helps with any coexisting sleep apnea. But two, and this is the big one for OHS, that gentle pressure helps the lungs work better all the time, improving that gas exchange so you can finally blow off all that excess CO2. And when that happens, that crushing daytime fatigue starts to fade away.
But here's the catch. The therapy only works if you use it night after night, and that's often the biggest hurdle. Getting used to a mask, finding the right fit, understanding why it's so incredibly important. If those things don't happen, people stop using the machine and all those amazing benefits disappear.
And that brings us to our final and honestly our most important point. Why is it so absolutely crucial to get this diagnosis right, to not just lump it in with regular sleep apnea? Well, the answer is that the stakes are just so much higher.
I mean, just look at this comparison. It's not even close. When you have OSH, your risk of being hospitalized, your risk of developing severe cardiovascular problems, and even your risk of dying, it's significantly higher than someone who only has obstructive sleep apnea. This is a whole different level of risk.
Because if you leave OHS untreated, that chronic high CO2 and low oxygen puts this enormous strain on the right side of your heart. That leads to something called pulmonary hypertension and eventually right-sided heart failure, which is exactly where our patient was headed. Getting that diagnosis and getting it early is the only way to stop that deadly cascade.
So I want to leave you with this final thought. For the millions of people out there dealing with obesity who are just bone-crushingly tired all day long, what if it's not just poor sleep? What if it's actually that faulty smoke alarm in the brain silently signaling a much more dangerous problem?